So your working diagnosis is a post-diagnostic shunt.
Yes.
BSC, which is known as a PH,
Yes.
right?
Yes.
And which became inoperable at around 5 years.
5 years.
I see some reason also fatigue and palpitation.
Still, I'm.
Why palpitation?
PH shunt.
Which controls palpitation?
PH
can lead to what?
I think non-arrhythmia. Is Parkinson because of arrhythmia or it is something else?
I don't think it is very.
What do you think? What do you think? What do you think?
pH can lead to what?
In a post-diagnostic shunt, what would be the commonest cause of volume dilatation?
Yes.
Before
To get absolute background package, like
can a post-diagnostic shunt be associated with AR?
Yes, sir.
Can you
Yes,
have produce
yes.
palpitation?
Yes, sir.
So why did you say that? Can it
Yes,
produce
yes,
fatigue?
yes, sir. Fatigue is, so fatigue can be added to a state of fixed cardiac output in her this stage.
And pH also can lead to RV dilation, RV dysfunction that can also lead to palpitations and fatigue. Fatigue, why fatigue in pH? Fatigue occurs with fixed cardiac output.
Correct.
If pH is
the battery approximately I wish there no shunt, actually is pH. But shunt into the pH, they kind of damage. That is major in the shunt.
yeah, but so then the pH is severe and there's no chance of integrity.
And PR produce palpitation. Can you get PR? Severe pH?
Yes, sir.
Can it produce palpitation?
Second to sensitivity examination. The patient is moderately fit and poorly nourished, conscious, cooperative, and oriented to time taken treatment. He has favor, or can you say diagnosis no clubbing, there is no edema, no signs of infective bronchitis and no signs of peripheral AR. Her height is 154 centimeters, weight of 36 kilos. BMI is 15 centimeters square. Her vitals, pulse rate is 100 beats per minute, regular, low volume. Bilateral pelvic pulses are equally felt in upper limb and lower limb. There is no radial delay, no radiofemoral delay, and with normal condition of the pelvic pulse. Her blood pressure is 100 by 70 millimeters of mercury, including position measured in right atrial artery. The same reading is in the left upper arm as well. Lower limb blood pressure is 106 millimeters of mercury systolic. Saturation at rest in room air is 96%, and on exertion it is 89%.
What about the saturation of the lower
Lower limb saturation is 96. 96 at rest. Yes.
This is important because
Yes.
saying practice fiction.
Yes.
Here you mentioned there is a difference time.
Yes. There is no differential sign.
On exertion also it's the same in both.
In exertion it is 89%.
So both upper and lower.
Yes.
Lower limb can be different. There is.
Differential cyanosis is a component of PD at exertion and
Go ahead.
How often you get differential sinus in PDA? All patients?
differential cyanosis occurs in the PDA opening after all the head and upper limb visits have. So sometimes that we can get reverse. I don't know if
There is reverse differentiation.
there can be said fair and upper limb can have kind of. Steadily there is prominent T waves and it is measured at 5 centimeters above the sternal line. Coming to cardiovascular examination, I would like to club inspection and palpation together.
Normal CLV.
It is raised
You said 5 centimeters.
above the sternal line.
And prominent people.
Prominent.
With normal CLV.
So what is the right angle pressure the 5 centimeter from the sternal line?
Um, of 7 millimeters. So 5 centimeters, we add another 5 at the right atrial height, which is about 10 centimeters of water.
Okay.
We convert it to millimeters of mercury by multiplying it with 0.7 as a factor. So that's 10 into 0.7 millimeters of mercury. Highly elevated, it is not very stable.
That's the mean, not the mean. The mean is like, you can't say that's the mean RNA pressure.
Okay.
Combining the inspection and palpation. Chest there is precordial bulge with hyperdynamic precordium. A text peak is felt in left fifth intercostal space at the mid-clavicular line. There is difference in nature. There is part of the second heart sound, way through parasternal heat, and epigastric perforation of RV bypass cell. On percussion, there is left second intercostal space and
It is early type or early type.
RV type.
Are there any epigastric pulsations of LV type also? You said epigastric pulsations of RV type also.
I mean, or
Epigastric pulsations are
RV
there.
type.
You can't differentiate RV or LV type with the epigastric. Can you do that?
What are the reasons of the precardial pulsation?
The RV hypertrophy, if the individual is thin, then there can be prominent aortic pulsation, abdominal aorta can be felt. If there is abdominal aortic aneurysm that can also be felt as epigastric.
Okay.
Good, one question.
Versatile liver, we are having there is right heart failure, second cancer.
Yeah.
Heart sounds, first heart sound is normal.
Are you wiser at the end of, before hospitalization? Have you come to what's the diagnosis closer to your diagnosis?
Just the findings you have from inspect after palpation, what is your, summarize the findings and tell us the possibility.
One, I'm going towards my diagnosis, but some pointers which are.
You can summarize the positive finding.
So the positive is there is features of PAH, the severe PH, whereby fibrous T2, parasol and heat.
First is I was on exertional. It is exertional desaturation.
Expression desaturation.
Then
There is prominent V wave. There is precordial bulge. There is hyperdynamic precordium and a RV type of effect with the fibrous T2 and parasol and heat. I'm also feeling dullness of the second F intercostal space. So I have features of severe pulmonary hypertension in a post-striker.
But then there is hypertension,
Yes,
hypertension.
hyperdynamic.
Then how to get hypertension?
That's what is a little contradictory to what I felt because I was thinking in terms of severe pH that I didn't have it, but that is what we're seeing. So that's why I would like to support it with observation. So first half sound is normal, second half sound is loud with a loud P2 component. There are no clicks heard. Split it is normally split. There is no.
Normally split with loud people.
Yes, sir.
That's When the-
I was expecting it to be a single edge.
No, normally make it moving.
It is,
Moving
normally
the,
it's, I can appreciate it in
it's
inspiration.
normal speed.
Sir, at expiration, there is a single heart sound, and in inspiration, there is getting of the second heart sound.
So that's happening here.
Yes, sir.
Can you name some conditions where you can get a reserved split but a loud beat? What my question? Your finding of a loud beat but a reserved split.
Yes.
A loud beat. From where all can you?
I question one question.
From whom?
I can't.
One is, I think, one is pre-tricuspid TSB where it's split magnetic.
Right.
And second is, if there's RV dysfunction, then you.
But still, you feel that the P2 is moving, seconds of the moving speed. Why there is a P2 is always, there is a few seconds. Why is that?
Physiology means with it is because of increased hangout interval on the pulmonary side. As it's right, and as compared to the aortic side, the hangout interval is more on the pulmonary. Coming to murmurs, the first murmur is loud, harsh, high frequency, a pansystolic murmur at the lower left sternal border of grade 3 by 6. It is best heard with the left lower sternal border between fourth and fifth intercostal space. The same murmur radiates to the apex and is heard at the axilla as well. Second murmur is the ejection systolic murmur of grade 3 by 6 in the left second intercostal space. It's also heard at the left upper sternal border.
Or the two movements. Don't we have any VDM?
Okay.
No, again,
Okay.
sure, one game.
Okay.
Game.
Which name do you use for this?
I would look for a mitral MDM.
Actually, what?
It would be so.
I need to affect now. That I need to affect first to expect actually.
I mean, if it was just a BSc,
With I
it
need
would
to
be-
affect technical. There no separate sum.
yeah.
You should expect that to
I tried doing master deck reading. Okay,
Taking some words, please now, there, mama, there. Please take it from me.
You said normal speed. Okay, he said normal speed.
Normal split PH or non-constant PI. But that could be IDV. IDV there.
The BSF is which one?
PSM is due to, I'm suspecting there is a ABPR cycles with regurgitation.
And it is something more than that, normal rate, get to.
Grade 3, so yes.
What?
That is possibly because of pulmonary arterial dilation. But it is not a.
Then AVPR we heard in the axilla also. That's what he mentioned.
In the radiating to the axilla, the intensity of the murmur does come down, and I also located at the axilla.
No, only, okay. So realization, you can feel the murmur at the.
If there is we are thinking of AV canal defect, then this murmur can be heard.
It can be a lot. What can we
And then where is the direction of the, at all, from what you're doing, where will be the direction of the jet, for it to be done in the axle?
So what's the working diagnosis after examination?
It is the inflammatory congenital heart disease, a large tricuspid shunt, or severe VSD, with left to right shunt. Severe,
Different.
if I should include AVPR, I would want to include a AVPR here, with severe PAH in sinus rhythm, not in congestive heart failure, with no signs of infective endocarditis, with anemia in embarrassing class 2, and no history of thromboembolic phenomena. Since I was thinking of PSC, at this age, could have isomegalized. There could be complications of isomegal in terms of polycythemia.
How frequent? Patients are used to families and it's going to those complicated things. If there is something. Okay, so can we go to the already minutes, we go to the investigation. So to differentiate you, which will be better, right?
Since I have got in
Any
AVPR,
functional diagnostic?
at this point, I would want to see if there is ABCD, maybe cannot effect.
So which one will you?
But the only thing that is going against her is I got a, and here,
If you can still you consider?
person. This is the history of sinus rhythm with heart rate of 100. The axis, each one is positive and this right axis
What is the PI?
is right axis is
PI. Okay, go ahead. Okay. Okay. Can you go to the previous? Because I'm not looking at that. But they go outside.
around +150. Right axis deviation with B1 is also showing predominant R waves.
Right, that's the reverse gradient. That is what?
ACS is negative.
This is equivalent to the big partner.
With positive.
What is it? This equivalent related to two is equivalent signal.
Is the perpendicular lead,
So what does it become?
AVL is upright.
Right.
Some right axis or left axis? Very broadly speaking. It becomes? Okay, with left axis with PAH.
What is the normal area?
B1,
B1 AVL,
Q is, Q is a
So,
special.
what's that? Then area two. Anybody? What about the loop? What's the normal? Plus and y. Okay, so what about B1? I will now go to the other ECG with the half standard. What of it? That may be the reason for your target. Yeah. So is there still volume overload of the electricity?
There are two ways in B5, B6. There is a volleyball or like.
What do you do?
Okay, shall we go to the move to the next?
The largest solid is cardiac.
Okay, good.
There is cardiomegaly.
Okay.
Cardiomegaly of RD type.
There are other different down, it looks like every type of.
What about the pulmonary artery?
Only have been enlarged.
What about the pulmonary vascular index? Decrease or?
There is increased pulmonary vascularity with Prrsentation.
There is a pectoral moving.
No,
Yeah.
Compare the lateral outline with the.
This growing,
at the larger one-third of the lungs, it's not disappearance of the pulmonary vascular. Just to clear.
So this you consider there is still some kind of still existing no problem for this type.
Because there is cardiomegaly, it's one of the features with ECG suggestion of volume overload. There could be some, I would still think there could be operative.
You said that is right side of cardiomyopathy, RV type of cardiomyopathy.
And you consider ABCD also.
Yes.
Do subsequent for another cap study to see confirm that still operable or not?
It is specifically I would want.
And the previous cap was 10 years back.
Yes.
So the pulmonary also very good for health.
But you were taking some oral medication. That's why.
Children have a better effect on either. Children don't.
At that point, it was told that it is not operable. Unlikely that another cat study would help, but I would have expected
the sir is asking which drug.
Yeah.
a pulse. I didn't.
Each of the pulmonary vasodilators have been probably useful in nasal bucket type of syndrome.
So Prrsentation, Prrsentation, and
What was it?
Prrsentation
Yeah.
with site trial,
It shows some benefit.
some benefit in isolation.
Okay.
Can see better in that.
Pointer.
That screen you can see better. Yeah, that's really helpful.
You,
Okay. So what will you do further for this patient? Do an echo. Okay, flow echo.
I can call it as I must every time.
So the initiating somewhere. Normal.
I think you guided it, sir.
And
Not cerebral collapse.
Is your
RB, EA, it is.
Higher pressure.
High pressure, over friend.
Any joint, any asking below.
No, sir. Nothing.
Or you want that to be free?
Nothing, sir. Open, sir.
Partially collapsing, friend has.
Time over.
Okay, go ahead.
Put this time over.
What you can comment also. Yeah.
So we can report.
LB is such a nice, beautiful model, the family may have been.
LP.
Everyone has the same level.
You have to increase the second one. Volume is.
Art is not that negative.
The Gali is, the base is Gali type here, and we can like, send me the time.
They got diffused, like,
Yeah, this is what I was saying. The LB is dilated. LB is dilated.
is dilated.
RB is not that dilated. If there was any defect,
Intact,
internal system looks intact. Pulmonary veins are they draining normally?
I can see, it's three pulmonary veins.
Yeah, good color.
So,
Okay.
so,
Yeah, what are you saying?
there's a large, PSC. And it's short,
Go ahead.
I think the defect,
Please. Yeah.
comment in that, yes,
not large,
Only say small, based on
we
what?
compare it with either with Shunt or compare it with the aerobic analyst. It is, here the defect looks almost equal to the aerobic analyst, I would say it is a large, case.
The biotics are following. The biotic with inlet extension.
In that,
The any gradient across
any gradient across the liquid speed, is there any Doppler?
it is PR. Yeah. What is the big PR? Come back. Yeah, PR is 41. So what is the P? What does it indicate? Big PR of 41.
Is it PA mean pressure?
Big PR corresponds to what?
Anybody? Deep, RA pressure.
So what will you do?
Doppler across the DSP.
Yes.
Yeah, I think so.
That's what I like.
No.
So you subject for more chemistry session to confirm.
It was significant, that will be volume more, lecture shows, three shows, before I think we should give one more chance and, do an event-based evaluation to assess the shunt.
So, therefore.
Yeah, like, but still, we can combine.
But all are.
Yeah.
Right. Also,
Other option is to give coronary vasculitis for someone, then, she is only a single bird.
yes,
Is it a single dose daily or multiple doses?
now maybe 25 milligrams, 50 every day.
Maybe you can try combination therapy and follow up the 3 or 6 months and then do a study. And situation they may not help, but can. She is going by single, but long term management will be advised.
Ah,
For example, she is there with diagnostic long term, what ways to be. She is a 19-year-old female.
I will medically put her on basic dialysis.
Okay.
Second, I would put her, I would ask her not to, I would put her, I would not avoid the pregnancy.
Okay.
And appropriate, contraceptive.
Not
education to be provided.
not getting it.
And
John.
I'll follow.
Hopefully,
You're going to the same year.
then
Now it is.
she's undergoing any dental procedures, we would also want her to undergo an effective
do you know
antibiotic.
anemia and the issues can correct it?
And yes, sir, anemia will worsen her independence, so we would want to.
Do you give vaccination? Do you give vaccination like pneumococcal?
Role of diabetics, role of protein antibiotics.
If there is,
Sir, we are ready, sir. We can join, sir.
we may
That's.
for the polycythemia, but, so antibiotics has not
That is my-
been
that is my-
beneficial for myelin or joint
But
beneficial.
I'm not.
Antiplatelets can be tried.
Not.
Anticoagulation will not.
Except.
That should be avoided.
So, I think, you did very well actually. But so, even though some issues were there, your discussion was good, so you brought in, Yeah.
Hormones are not very,
Ma'am,
What do you think is the murmur, you know? Systolic murmur is a lower. When you're trying to drink CR and then you can.
where is the cat?
I just want to give some general advice applicable to all students here. Generally be prepared for 3 things. One is be ready for a summarization at the end of. So one is be prepared to summarize, be proactively prepared
Is it there?
at the end of.
No, sir.
Then at the end of examination, sort of hospital. That's the second step. And third is particularly when you're towards the end of the day, when examiners are also in a hurry. Somebody might just ask you before presentation, give your diagnosis, salient history and examination support. So, proactively for every case, be prepared.
Can this be shown directly?
Then you're not floundering the task. You were very well prepared at the end of history. That's my impression. You were very well prepared at the end of history, but at the end, short of hospitalization, you were not that well prepared. And at the end, you were further lost. So you have to actively prepare your words in this kind of. Thank you.
It's not easy to come and stand here very, and all the volunteers who have come and,
What? No, sir. No, sir.